Hi, everybody. Thank you so much for joining our Facebook Live video chat. I'm Shauna Spencer, the Director of Brand Marketing at the Crohn's and Colitis Foundation. And living with IBD as a woman can come with some concerns. So the disease can have an impact on intimacy, conception, pregnancy, motherhood, menses, and menopause, all of it. And I understand this a little bit too well, some of them, because I myself am a Crohn's patient and the mom of two very little ones. So I'm very excited to be joined today by Dr. Sushila Dalal of the University of Chicago. Dr. Dalal will be discussing issues that women with IBD may face during their disease journey. Dr. Dalal, thank you so much for joining us today.
Well, thank you so much for having me to discuss this really important topic.
Awesome. Well, please note, quick disclaimer before we dive in here, that any information shared during today's chat is for educational purposes. The information shared by the speakers do not reflect the official position of the foundation. And as always, please consult with your doctor before making decisions about your medical treatment in IBD. To learn more in general about women, pregnancy, and IBD, you can visit www.crohnscolitisfoundation.org. And we're going to go ahead and we have some questions that we've collected that Dr. Dalal is going to help answer. And we have about a half an hour to answer those. So we'll do our best to get to all of the questions. If you have a question, please feel free to put it in the comments. If we have time, we'll get to those as well. And if not, we'll follow up. So diving right in, Dr. Dalal, what is one of the top concerns that you hear from your female patients, and how do you address it with them?
I think that my female patients are often concerned about the safety of their medications. I think all patients are concerned about this, but I think for females in particular who may be thinking about having children, they're really worried about how that may impact their ability to become pregnant and the safety for their baby. So I think even when I'm talking to an 18-year-old or a college student who's not thinking about it at any time right now, they are sort of thinking in the long term, if this is a medication that works for me and I stay on it, what are the long-term ramifications? Is this going to prevent me from doing anything that I want to do? And how will that impact safety in the future?
And we have a couple of those questions we're going to get to specifically in a little bit here too, that came up as well. So no surprise there. So one of the first questions that we got was, how can Crohn's or colitis have an impact on a woman's menstrual cycle?
Yeah, I think that's often one of the early things that happen to women that have ulcerative colitis or Crohn's disease. There have been survey studies that have shown that in the whole year before the diagnosis of ulcerative colitis or Crohn's disease, women may notice alterations in their cycle length or their cycle duration. So those might be some of the early signs that things are getting a bit off and that symptoms are beginning. We know that also with illness, if there's a flare-up or there's more disease activity, there can be alterations in the menstrual cycle. Importantly, a lot of women have changes in their symptoms with menses as well. Many women will have more diarrhea during their cycle or more abdominal pain. That can be true for women with IBD or without IBD, but I think for our patients with IBD, that's only magnified. And it seems that there is a hormonal influence on the way our GI tracts move, the way we perceive pain and the way that we experience pain, and even on things like the gut bacteria and the permeability of the intestine. So the hormonal influences definitely play a part in GI symptoms.
And I can definitely speak from personal experience. That's something that I've talked to other friends about as well, and I think a lot of people can relate to. The next question that we had is, how can I find an OBGYN who knows how to treat women with IBD? And should I see a regular OBGYN, or do I need to see a maternal fetal medicine specialist?
Yeah, so that's a really important question. We know that actually one of the best things that women with IBD can do to plan for a healthy pregnancy is to actually get preconception counseling and actually talk with both their GI doctor and their OB doctor beforehand. And all women with ulcerative colitis or Crohn's disease should see an MFM specialist or maternal fetal medicine specialist. That's a type of OB that's undergone extra training, often 2 or 3 years of extra training, to learn how to manage patients during pregnancy that may have other conditions that would impact their pregnancy. So it's a good idea to go to an MFM for consultation, and then they'll make a good plan with you for what monitoring is needed. For each person, that's going to be a little bit individualized what they think is best. So it's good to see them early on so that they can provide their recommendations even before you may become pregnant and come up with a good plan with you.
Thanks for that great info. So then the next question we have is, what form of birth control is safest for women with IBD to take? And can certain birth control methods trigger a flare?
So in terms of birth control, oftentimes this comes up because, as we mentioned earlier, menstrual cycle can really impact symptoms. So many women are looking for control of those symptoms. So in terms of birth control, we know that estrogen can increase the risk of blood clots, and there is actually an increased risk of blood clots in people who have active inflammatory bowel disease. There is expert opinion in the IBD pregnancy pathway that trying to avoid estrogen-containing contraception may be advised, especially in people who are at higher risk of blood clots. There is a recommendation for long-acting reversible contraception, such as hormonal or non-hormonal intrauterine devices, or other long-acting forms of contraception, or in some cases low-dose therapy that may contain estrogen and progesterone.
So then what can women with Crohn's or colitis conceive as easily as other women? Kind of the flip side of that question.
Yeah, so there are a number of factors that can affect that. So surgery, having had a pelvic surgery, so having had colectomy with a J pouch in particular, is thought to impact ability to become pregnant. That we're not sure if that is as true now that many surgeries are done laparoscopically or minimally invasively as it may have been in the past. But in patients who have had a J pouch surgery, or in some patients who have had an ostomy placed, they may have some scar tissue that may make it more difficult to become pregnant. We think that once our IBD patients become pregnant, they're able to carry the pregnancy as people without IBD would, but sometimes there's a little bit of difficulty with that. And because of that, we recommend that if it's been 6 months without becoming pregnant, that an IBD patient see someone to discuss their fertility.
And who would you suggest to see a fertility specialist?
Yeah, see a fertility specialist, exactly, to start to think about if further evaluation may be necessary at that time.
So then what potential long-term effects what are the potential long-term effects of biologics on fertility? I know that even just having a lot of friends, as a Crohn's patient, having a lot of friends that have IBD as well, I hear this one a lot.
Yeah, I think that is a topic that many people are thinking about and are worried about, but we don't have any indication that our medications themselves impact fertility. However, we do have an indication that active disease may impact fertility. So I think making sure that those medications are working for you and that your disease is under good control and that you're under stable remission is one of the ways that we can really make sure that fertility is preserved.
And that's a great lead, and I'm actually going to skip a question here to another question we had, which is how long should you be in remission before you get pregnant? I know I can talk a little bit afterwards about my experience with this, but I know that was a big key to me having my kiddos is trying to take as best care of myself as possible and get in remission.
Exactly. So it's really important to be in a stable remission before pregnancy, and we recommend that you're in remission for at least 3 months before trying to conceive. Know that one of the biggest predictors for having a flare active disease during pregnancy is having active disease beforehand. So really making sure that if a change has been discussed, or if there are some active symptoms, that really disease is well controlled for at least 3 months so that everything is stable during the pregnancy is really the best thing that a patient can do to have a good outcome during their pregnancy.
And I know personally, so my husband and I tried to get pregnant for 3 to 4 years with our first daughter, and I was in and out of flares that entire time. And when I finally got pregnant, my Crohn's pretty much more or less went into, deep remission or went away. I didn't really have any active disease at all for the first time in about 10 years. So getting pregnant with our second was really easy because I was in remission and doing really well. So I can tell you that I've personally experienced that and talked to others who have. And my personal recommendation, this is just my personal recommendation to anyone that's going through that, that's really a challenging situation to go through and to try to get pregnant and to battle diseases at the same time. So my recommendation would be to find a community or support. And we have a lot of options within the foundation of that, whether you join one of our programs or join a support group or online community. That's what helped me, because that is a challenging process and something I hear a lot from IBD patients.
Absolutely. That can be a really stressful time for patients.
So then another question that we got was several IBD medications are listed in category D for pregnancy. Can you explain what that means and what the risk versus benefits are for continuing that medication during pregnancy?
Yeah, so the category D system is a way that traditionally medication safety was looked at. And actually, they've sort of moved away from that because it is a little bit absolute. It says, that if there's risk, consider not using this medication. And now the classification system has actually changed a little bit to look more at the large registry studies that we have in certain conditions, looking at particular patient populations that have tried the drug and sort of weighing risks and benefits more. So in terms of our IBD medications, as we were kind of just referring to in our conversation, we think that the greatest risk to pregnancy is active disease. And so along those lines, it's really important to stay on effective medications in order to keep disease under control. So in terms of medications, methotrexate needs to be discontinued, stopped 3 months before conception. And our newest medication for ulcerative colitis, tofacitinib, there is animal data at doses higher than what we use in humans, but still, nonetheless, there is some data that suggests that birth defects may occur at doses higher than what we use. So at this time, we're avoiding methotrexate, and until we have more information on tofacitinib, would recommend not becoming pregnant on it. However, we do have data in IBD patients that suggest safety for continuing our other medications to maintain remission. You mentioned in particular 6-MP, one of our immunomodulators. We also use its sister drug, azathioprine, sometimes. And that medication, it's a little bit more complicated. There are large registry studies in ulcerative colitis and Crohn, so studying large numbers of patients on those medications that suggest that the risk-benefit of using that medication is in favor of continuing it to maintain remission if that's the medication that has made you well. We don't start the medication new during pregnancy because we don't know who will get a side effect or to it. So we continue it if it's been working, but don't start it as a new medication. And in some patients who may be using those medicines in combination, who may be on 2 medicines, like 6-MP or azathioprine plus a biologic, if possible, consider stopping the 6-MP or azathioprine so that you're only on 1 medication. But a medication plan is always something that's tailored between the patient and her doctor because there are, individual factors to consider of how difficult it was to get into remission and maintain remission, because we really want to ensure mom's health.
Absolutely. I can tell you as a mom that if mom's not healthy, nothing.
Exactly.
So the next question was submitted via email. This woman said, both my mom and I have Crohn's disease. What is the likelihood that my baby will develop IBD? Is there a genetic test to find out if my child's at risk?
Yeah, I think that this is something that's on the mind of a lot of patients. And we know that historically, IBD patients often chose to remain childless, I think in part because of some of these concerns. Genetics in IBD is really complicated. There is not a gene test for it because there's 200 gene locations that are associated with risk of ulcerative colitis and Crohn's disease. And we know it's a complex interplay between environmental triggers and genetics that might cause IBD. But we think that if mom has Crohn's disease, the risk of passing it on to an offspring is about 2.7%, and in ulcerative colitis, lower than that, 1.6%. If there is more family genetic risk, like the patient that sent in that question has a mom with IBD as well, those numbers might be slightly higher, but we do think that risks are still low.
And I think for me as a patient, that actual number was really comforting to hear, because I think it's something that I thought was a much bigger risk in my head, because it's just scary. It's your kid. So I can definitely tell you people out there relating to that question. And for me personally, that was comforting to know. And I learned that stat before we had our kids. So, and it just drives me harder to find cures and get cures in the future just for any kids that do get diagnosed. So then a couple of more questions. Is there anything to watch out for during pregnancy that would be different than a pregnant woman without Crohn's or colitis?
Yeah, absolutely. I think that as we're discussing, close monitoring is important. It's important to see both your gastroenterologist as well as your OB during pregnancy regularly. And it's important that your gastroenterologist make sure that you're maintaining remission, because we know that that's an important predictor. Nutrition and weight gain are important to keep in mind. If you're a Crohn's patient who's had a surgery in the past, in particular, vitamin B12 and iron levels may need to be supplemented. Folic acid supplementation is something that's recommended for all women thinking about pregnancy, but there are some medications that we use, in particular sulfasalazine, that may require a higher dose of folic acid. So in particular, it may be important for your doctor to check some of those vitamin levels beforehand, make sure they're where they need to be, and make sure you're monitoring them during the pregnancy. Consulting with a nutritionist may be a good idea if there are any concerns about weight gain. So that may require a little bit of extra attention.
And the next question goes to kind of what happens if you end up having a flare. So this woman was wondering, what's the best way to treat a flare during pregnancy that's also safe for the baby?
Yeah, I think that that's, of course, a fear that a lot of women go into pregnancy thinking about what will happen and how will we manage it. And I think we would manage it just as we would if there were a flare otherwise. We need to use the medications that we would otherwise use to manage your flare. So sometimes steroids are necessary. There was sort of old data looking at steroids in the first trimester of pregnancy, worrying about cleft palate deformities in that setting. But there have been much larger studies done afterwards that suggest that that's very low risk. We never want to use steroids if we don't have to ever in IBD management, but if they're needed for a short course, we can do that. If we need to start a biologic medication to get disease under control during pregnancy, we can do that because really the risk of active disease is what's highest risk for preterm delivery or lower weight babies. So we really think that the priority is getting the disease under control.
Definitely. So the next question we had is a C-section safer or worse than regular delivery for women with IBD? What factors should go into deciding between a C-section or natural birth? And I'm a mom, so I'm just going to add in when and if you have a choice, because you don't always have a choice.
Exactly. And I think that is a really important point because for the most part, the decision of what mode of delivery is best is the OB's choice of what they think is most appropriate. However, there's a couple situations where we consider it. In Crohn's disease in particular, if there's active perianal disease, so active fistulizing disease, perianal fistula or a history of a rectovaginal fistula, in that setting, we would recommend a C-section just because we know that tears and damage to the anal sphincter is higher risk in that situation. So active perianal disease, if it's old perianal disease that's completely healed and hasn't been active for many years, then that may not be necessary. And then patients that have undergone J-pouch surgery. We know that continence with a J-pouch, we really want to be very careful with any potential injury to the anal sphincter. So oftentimes J-pouch patients will undergo C-section. It's important if they do have a C-section planned that they have notified a colorectal surgeon or that there is one available in that hospital in case there is scar tissue or other assistance that their OB may need. But those are really the two settings where we would think about it and have that discussion between the gastroenterologist and the OB. But otherwise, it really is at the discretion of what the OB thinks is best.
So then thinking through after delivery, what IBD medications are safe while breastfeeding? I know that that's very important to a lot of women.
Yeah, absolutely. We really think that most of our medications are in extremely low levels in breast milk or are practically undetectable. So for biologics, we have the most information for infliximab, or Remicade, or adalimumab, Humira, because those have been looked at and the levels are much, much, much lower than what's in the bloodstream and in a level that's not thought to be significant. The other medications that we would want to avoid in breastfeeding would be methotrexate, and we really don't have data on tofacitinib at this point, so we're avoiding those in breastfeeding at this point. But the other medications we do safely continue.
And then what is a rectovaginal fistula and why do women develop them, and what's the best course of treatment to heal them?
Yeah, so rectovaginal fistula is a connection that's developed between the rectum and the vagina. So sort of like a little tunnel that's formed between those areas. So that can happen sometimes in patients as an obstetric complication after delivery in patients that don't have IBD, but it can happen in Crohn's disease patients that have inflammation in that rectal area, just as fistulas can happen in other parts of the GI tract with Crohn's disease. So the best treatment is really getting the inflammation under control medically, first making sure that the rectum is healed, and then often a colorectal surgeon is needed to repair that area. It can be a challenging area. It's a challenging problem, but colorectal surgeons do have several techniques that they can offer once the inflammation is under good control.
So then our last question is, can having IBD have an effect on menopause?
It's a great question, and I think it's one that we really don't know the answer to at this point. There really is not a lot of information on whether it affects the age of menopause or affects, how patients experience it. We really don't know at this point, but it would be important to study.
Well, I think that's about the end of the questions and the time we have. If you guys have a question that you haven't asked, put it in the chat box and we will try to get back to you. As always, if you have any additional questions about anything IBD related, about women, pregnancy, and IBD, please feel free to contact the IBD Help Center, and that's at info@crohnscolitisfoundation.org, or you can call them at 888-MY-GUT-PAIN, or finally visit us on the website at www.crohnscolitisfoundation.org. Thank you so much, Dr. Dalal, for joining us today and talking to us about women and IBD. It's obviously a topic that I'm very passionate about because I live with it on a daily basis, and I can tell you that being a mom of two while in a flare is not an easy thing. Having IBD and being a mom in general is not an easy thing, and other women's issues. So a huge shout out to all of our mothers out there as Mother's Day approaches who are IBD warriors or support an IBD warrior, and all of our women out there. Thank you for your involvement, and thank you again, Dr. Dalal.
Sure.
Have a great rest of your day.
Thanks.
Bye.